Dr. Robert Kelly, welcome to Weird Sauce, and thank you for welcoming us in the UK. I believe you are based in, from us here in Singapore. Could you kindly introduce yourself to our audience?
Thank you, Florence. So my name is Dr. Robert Kelly. I am a cardiologist and lifestyle medicine physician. I'm actually based in Ireland, which is just across the water from the UK. And I also have a particular interest in tiny habits coaching and behaviour design to help patients change their behaviour when it comes to heart disease and lifestyle medicine.
Excellent. I did detect a slight accent. I wasn't going to jump in that water yet, but I did detect that very lovely accent. So tell us about the relationship in your mind and in your practice between lifestyle behavior and health or disease.
So I'm a cardiologist who spends a lot of time trying to help patients both prevent disease, treat disease, and potentially reverse disease. And that's what lifestyle medicine effectively does. In cardiology, I put stents in patients who have had heart attacks or who have chest pain, whereas the patients come back, maybe the pain is gone, but they come back with all the problems that gave rise to the heart problem. And those particular challenges have to be met. And so I have found over time I can give them lots of information. They don't remember it. And truthfully, the only way I can actually impact their behavior is to show them ways that they can actually change their behavior and bring them through that. And so that's where my interest has evolved over time in practice.
And so when we talk about lifestyle behavior, I think every individual, every physician, and possibly every culture has a different definition of what lifestyle behavior actually are. So what are those for you?
So lifestyle medicine includes key pillars, as they call them. So it's about healthy eating, taking some form of physical activity, getting a good night's sleep, managing stress. And then there's an important piece around connections and socializing with your friends and family and other people. There's also an important aspect too, which I can't forget, and that is dealing with drug intake, stopping smoking, and not drinking too much alcohol.
Right. So very, very straightforward definition, I suppose, of what happens over a cycle of 24 hours and that which we must do. Otherwise, we're sort of dead, because if we don't have a heartbeat, we're dead. And if we don't sleep after a certain time, we will be dying. And of course, food intake. So let me put some perspective into this, because that's a field that is so broad. And COVID, as we are still in it right now, has brought to light the importance of metabolic health, the forefront of some of these frailty in relation to COVID risks. So have you seen particular impact of that in your practice? Have you continued to practice medicine during this lockdown, or have you had a lockdown or many lockdowns in Ireland? And if so, have you seen the sort of parallel occurrence of metabolic problem, cardiometabolic problem, and an enhanced risk or enhanced difficulty in dealing with COVID and COVID impact?
So COVID came to Ireland in March of last year. The hospital system in Ireland is not quite as organised as Singapore, so the government chose to nationalise all the private hospitals. I work in a private hospital, so I effectively ended up out of work for a number of months. The COVID national system took in all the patients to manage all the acute COVID patients. With a high mortality, not quite as high as other parts of the world, because we're a relatively small country of just under 5 million people. And we've had 3 lockdowns. And the most recent lockdown we came out of literally 3 weeks ago. We are all still social distancing, wearing masks. We have a situation where about 2 million people are now vaccinated. And we've managed to cut. We had a huge impact from Christmas of last year, where we had a very significant lockdown, where the country was effectively locked down for 3 months because of a very high mortality risk amongst the elderly in particular, which was there at the beginning too. Very high hospitalization rate, high intensive care use, well beyond the capacity of the system. We've managed to come through that. It's happened because of extremely good medical care. It's happened because of vaccination. And it's happened because the public did adhere to the social distancing and the vast majority of people stayed at home. But that has come with consequences for the physical and mental health of those people who have survived. A lot of it happened around Christmas, where the children of people returned home for Christmas, stayed with their parents, and regrettably they gave their parents COVID, and some of those parents died. In terms of the cardiometabolic profile, the people in Ireland who've died from COVID have been elderly, those with a history of neurological conditions, which are largely dementia-related conditions, who live in nursing homes. And then the group of people who have died have been overweight, usually severely overweight, people who have high blood pressure, who have chronic heart conditions, who have chronic lung disease, which is often related to smoking. They're the groups of patients who've all died as a group from COVID-19. There is a group of people who have died who didn't have any medical conditions. But by and large, it's all those patients as opposed to healthy, normal people. There's plenty of other people who have COVID-19. There are several stories of people surviving COVID who have some of those metabolic conditions. But on the balance of things, the vast majority of people who've done badly have had these metabolic issues.
Yeah, so that seems to be something that we hear also from other countries in the world in terms of this prevalence and this profile of how that disease, at least the original strains, or maybe strains to come might be slightly different if there's some variant or escape variants. But let's go back for a minute, if you'd like, in this concept of lifestyle behavior. So I assume as a cardiologist, of course, there's a direct connection between the heart health and in general cardiometabolic health and lifestyle behavior of people. But what led you to think that you would be interested in things that are maybe not pharmacological in nature? So they would, like, intervention that would not necessarily lead to a medication. And what was the thought process? Was there an event that led you to be influenced and actually think about this? So I'm always very curious about this because it's not a linear path from medical curriculum to this.
So let me share with you the story, because there usually is a story. So I trained in the UK and I trained in the US, and I returned to Ireland in 2007 as a consultant in cardiology. I established myself in private practice in Ireland, which relates to being self-employed, buying your own practice, and then effectively starting with no patients and growing your business. I also decided to take on a lot of other work. I became the lead cardiologist for the hospital that was attached to my practice and built the cardiology department. And to help my skill set, I took on an MBA as well, just for the small amount of time I had as a distance learning a decision that I made. Unfortunately, with all that on board, I suffered an episode of burnout where I actually collapsed at home a couple of months into my job. And in truth, having returned from the US, I was carrying a little bit of weight because the diet is a little bit different over there compared to Ireland. I was very busy in my job, so I may have foregone a little element of exercise. But on return home, having been through that episode, as a physician, I was most concerned that I had let that happen to me. And one of my responses, being a very scientifically orientated person, was to search for a meaning as to why this had happened to me, even though, as you say, the lifestyle behaviors would be quite obvious. And so I came across lifestyle medicine as an area of medicine that encompassed the idea that my lifestyle could have been the trigger for what happened to me. So, obviously taking on too much work, carrying lifestyle behaviors that were not necessarily conducive with good health at that time, and the contribution of that to what had happened. And it was through that I explored lifestyle medicine. I became very involved in it through the American College of Lifestyle Medicine. I became very involved with bringing it into Ireland and with teaching it, with trying to establish it as a practice. And I became board certified in the specialty because I felt I needed that to give me the actual authenticity to practice that. And so I have found reasons within that. I'm very bought into lifestyle medicine, and I practice it regularly, both as myself, but also with the patients. And so from that into cardiology, it's been very apparent to me, as I said before, that getting to the root of the problem for a patient goes well beyond putting stents in and treating patients with tablets. There's no doubt that you need certain tablets. You need aspirin if you have extensive heart disease or if you've had a stroke. You need cholesterol tablets in certain circumstances. But there's plenty of patients who aren't in that group of patients. There's plenty of patients who have significant lifestyle issues when it comes to heart problems, particularly stress. And unfortunately, in Ireland, we are one of the more obese countries in the world. Despite our small size, we are very westernized. We used to have a significant smoking problem. It has diminished, but not gone away. We have a growing substance abuse problem like other parts of the world. We are not the most active, although COVID has created an increased level of activity. And we have to deal with a situation that a lot of the things during COVID, as an example, with social isolation and cocooning forced by lockdowns, is we're going to have a huge physical and mental health problem going forward for the next 10 years at the very least. And lifestyle medicine has a key opportunity in dealing with that as well.
So that's really fascinating what you just said about burnout in medicine, because obviously that's what I do as a profession, and that's what also led me to move into lifestyle behavior analytics for other people. And burnout in the healthcare professional is a pandemic before this pandemic that nobody's talking about. And I'm just really want to hear from you. What do you think of this kind of cycle of washing machine abuse to some extent that this current payload of healthcare workers has been put through months in, months out in both public hospitals and I suppose even private hospitals? And assuming that they were already not in tip-top condition to begin with, because I've worked in the UK, I've worked in Scotland, in some of the hospitals up there, and nurses and physicians are not always in the best metabolic health themselves. Not to any fault specifically, but just that's the fact. And so I'm wondering, given where this started, and now we're looking at 15 months of excruciating, pummeling sort of, timeline, what do you think the outcome will be, since we don't have a plan B, we don't have like a spare group of people that are fresh and we're just waiting for them to show up?
So I think it's a fascinating question. I have no doubt that the healthcare profession will be affected in multiple ways. So from the outset, one of the biggest challenges, as you identify, is about 80% of healthcare workers probably already suffer from burnout before you come into COVID. And it's the same of all the lifestyle issues. They were all there before COVID. COVID was just a tip of the iceberg event that was already over the situation where there was lots of issues with lifestyle. I think for physicians, the other issues are the COVID situation led to an awful lot of stress, dealing with people dying in front of you, making decisions as to who got treated in what way, dealing with close family members who had died. So it's very akin to war, which in certain parts of the world is something we're not used to. I mean, Ireland's a neutral country. We don't have an army that goes to war in other parts of the world. So it's something very foreign to us as a nation to deal with. I think the other aspect to that is you had a significant amount of mental health issues that came up for physicians. And unfortunately, and there were a couple of stories in America of, I know one in New York, of an A&E consultant who actually committed suicide jumping off the hospital she worked in. But the level of burnout, as I said, was already there. So dealing with the acute stress of COVID, unfortunately, has continued by 18 months of duration. The rostering of physicians and surgeons has been challenging because of the shortage of staff. And so people are working extremely hard, well beyond their normal length of time. So it's only natural that they will be under a lot of stress. It's only natural that the time will not be there to look after themselves. And regrettably, it's only natural that the profession will struggle to retain its staff, not just physicians, but also nurses. Now, you have to consider as well that the economic impact of COVID has not truly been felt yet. Now, one of the challenges with that is countries are going to have to increase their taxation rates. A lot of people won't want to stay in the countries they're in because they won't be able to afford the cost of living. So, when we had a recession, I'm old enough, back in the 1980s, we had a huge shift in the population in Ireland where a lot of people went to the Middle East to work in hospitals there because they paid much better. And a huge amount of our nurses left the country and doctors went to work in the US. And I think, as long as COVID gets sorted out in other parts of the world, you're going to see the same trend emerging all over again. And you're not going to have the staff here to manage our own healthcare systems. There's already a huge shortage of doctors and nurses long before COVID happened as well. And there's a massive global health problem out there, as you can see from the experiences in India and South America and still to come in Africa, that's going to need a huge amount of healthcare input. So I think the profession is going to be hugely threatened in terms of its capacity to maintain a service all over the world. And I think doctors really do have to take some steps to manage their own self-care, and so do nurses. I mean, it is extraordinary as to what you can put yourself through. One of the major challenges in healthcare, a little bit like my story, is there's a very famous historical line about physician, heal thyself. And the biggest challenge that we as doctors have is this lack of self-compassion and this idea that we're there to please everybody else. And it's kind of the esteem that we get because somebody says, thank you, you've done a great job. When the reality is that you haven't done a great job for yourself. And that's why so many doctors end up in the problems that you and I are both familiar with.
I couldn't agree more. And I actually find it really scandalous after dealing with this for years and years and years at the physiological level for physicians or nurses. I did find it scandalous that there were no organized structure to provide not a remedial help, because that's something that you do when it's already late into the problem, but rather either prevention by ways of physiological preventions, science-based prevention, not just chatting with someone because they had a problem. Not that it might be useful, but it's not as useful as physiological intervention, sleep management intervention, mobility intervention, etc. And I find it scandalous 10 years ago, but thinking, well, surely given the advent of wearable devices and data and AI, surely people will, turn their heads towards what is essential in healthcare, which is the healthcare staff, because without them, you have nothing. And I'm still at this point. I'm still looking at it, and there's no momentum. And that was before pandemic. And so in this past 14 months, with all the data that you and I know about what's really going on from the inside, that is a black box because nobody really talks about it. On occasion, we talk about one doctor suicide, but that's it. We're not looking into numbers. I'm just thinking, well, if this wasn't there yet, and nobody's talking about we should institutionalize health for the healthcare workers, because that's essential. I don't know how that is going to be sorted out. There's no momentum, at least in Asia. I haven't seen momentum in the medical education. Maybe you can talk about what's going on in Europe at this level.
So in terms of lifestyle medicine, just as an entity, because it covers stress and it covers those physiological aspects that you refer to, I would say that there's different kind of routes emerging. So in the UK, you have a British Society of Lifestyle Medicine that's been around for several years. It's very active. It's doing its best to get into primary care and bring the lifestyle medicine into the community. In Europe, you have different groups. You have the European Lifestyle Medicine Organization, who cover a large range of specialties. A lot of it's private practice based. There are a few academic institutions, but it's young. The institution is only about 3 or 4 years old. It is growing, but there's a lot of opportunity, particularly in nutrition in Europe, around things like Mediterranean diets, which really, really work. But they're also very well studied in terms of their impacts on health. Again, the challenge is getting people to do it. So I think in this part of the world, there are the startings of things, but the stress problem and burnout problem has been there for decades. And you're right, the institutions have not opted to grasp this. They haven't opted to grasp it amongst their own senior management. And it's very sad because as a doctor, it feels like you're a commodity in that, you're very replaceable. If you're not up to the job, well, so what? Let the next person come in and take the job. Nurses are experiencing the exact same thing. And there's also a sense, I'm involved in a project at the moment to try and do something for healthcare professionals here. You get the sense that you're not really valued that high because you get offered some alternative, inexpensive health and well-being program that you could pick up online yourself. But what you actually really need is you need either one-to-one, and you often need one-to-one care because the thing about burnout is that a lot of people see it as a stigma. It's a bit like mental health issues. A lot of people don't want to share the conversations. Physicians don't want other physicians to realize they're weak. And nurses in general, there is a high absenteeism rate that comes from this, but they don't feel they get listened to. And I think it is very concerning because I know that's universal around the world. I know it's no different. And some of us, it's our own fault for letting it happen. But at the same time, we spend a lot of time blaming everybody else, and we don't spend a lot of time trying to come together to deal with the problem.
Do you find it as a doctor and obviously as a human being? Do you find it that all the stuff that sometimes pop up as a barrier to behavior change, that you may encounter with your patient, you find that barrier within yourself? And if so, could you just give an indication to someone who is listening to this podcast and might not be a doctor on how you manage to get around it, or to, to find a solution to that?
So in my own circumstances, it's interesting. It's taken a long, long time to work out realistically why I had a burnout episode. And so you might think, obviously, I burnt out because I was carrying a lot of weight. I hadn't done something about it. I was a little bit inactive. Work is very stressful and I wasn't sleeping very well. So I was kind of a sitting target for this. I actually dealt with these things very effectively. I lost a considerable amount of weight. I went on a healthy eating program. I actually subsequently set up my own nutrition practice as a consequence for my patients because of the impact I got with the nutritionist. And I've been able to sustain that improvement thereabouts. So a few little up and downs through COVID. I'm only human like everybody else. But I've also managed to return to taking some physical activity, which does not mean that you have to run the marathon. It just means you have to get up off the couch or off the chair and get out and about, get the fresh air, maybe walk around. But more importantly, do the things you like. In terms of the sleeping as a consequence of those two activities, I found in general I was sleeping better. But unfortunately, over the period of time, I also found myself coming very near to burnout again as a consequence of the workload and the pressures that I felt I was under. Now, for people out there, health is not just about the absence of disease or physical illness. It's also about a lot of other aspects that you don't ordinarily consider. So in your part of the world, spiritual health is very strong with Eastern medicine. That is not the case in this part of the world. There is some element of religion, but the religion has kind of not as embodied here as it used to be. And you have other aspects to consider, like your financial well-being, like your mental well-being. And so a lot of people in my situation put yourself under huge financial stress as a consequence of big bills, setting up a practice, buying a house. That is the same in many parts of the world, and you see that in the US. Doctors take on huge loans, and I'm sure it's the same in your part of the world. So you expose yourself to massive triggers of stress that have, if you're not absolutely right, they do expose you to a risk that you're going to get sick. In my circumstance, let me just share with you for a minute what happened with me. So I did all those things. I found myself getting much, much better. And then more recently, what happened to me was a very close friend of mine became very unwell with a cancer diagnosis of the same age as me, a classmate of mine from medical school living abroad. He ended up having a lot of surgery. Fortunately, he's done very, very well. But the whole episode triggered for me in my life sort of concerns about mortality. Now, one of the challenges around my personal mortality was this risk of having burnout, of this risk of having pressure in my own life, and as a cardiologist, the potential risk it might do to my own health. And so the burnout issue became very close to me again and started to trigger. And I got a little bit worried, got very drawn into my lifestyle again, but still something was missing and something wasn't holding right. So I actually had explored so many different things, so many courses, so many books, that beyond lifestyle medicine, I couldn't get the answer I was looking for. And then I was introduced to a health coach who actually turned out to be a mindset coach. She's based in the US, and I signed up as a client. Now, I have never, ever done this before. I wish I had done it before, because through the conversations with her, what I discovered was when I was much younger, when I was in medical school, my brother dropped dead when I was in my final year in medical school of a sudden cardiac death, which naturally had some impact on me becoming a cardiologist. My friend's illness recently, and then my own father died a couple of months ago. A lot of those events kind of came together as a perfect storm, and I could sense that I was going to burn out all over again. So I discovered that ultimately when I burnt out, coming back to practice, it was actually largely to do with my inability to have dealt with the circumstances that I became aware of in my own life. Now, very fortunately, in the last couple of months, through a mindset coach, I've gone through a lot of self-reflection. One of those things that I mentioned earlier would be the concept that I would be huge into self-esteem as a doctor. I would always love the fact that I get a smile on my face or a well-done doctor from a patient. But yet, my own self-compassion as to truly what I care about being a doctor was not something that I valued high enough because I had let the other take over. And so really looking after my own self-care beyond the physical aspects has been a huge awakening to me, and something that I've started to adapt to my own practice particularly with dealing with colleagues, particularly with helping nurses as well, and people, individuals who are not healthcare professionals, in overcoming and dealing with a lot of the challenges that both COVID plays, but also that life and work actually place on the vast majority of people.
Yeah, I think this confluence of physiological burnout, which are very, very easily identified if you look at data, both in terms of glucocorticoids or inflammation in the body, etc. There's a lot of very clear markers in those fields. However, as you pointed out, the markers for cognitive and brain function, which then leads to the sense of psychological well-being, which then, if left untouched, can become mental illness or mental dysfunction, is something that is really very, again, not approached. And there's tend to be a separation in medicine as well as in practice, even in lifestyle medicine, of cognitive and brain health or mental health evolution and the body. And in my experience of dealing with burnt out doctors, both in the thrall of burnout, seeing how to settle prevention and looking at it also for nurses, what I came aware of is it was almost impossible for someone in the middle of complete physiological breakdown to be able to be psychologically well. So the relationship and the alignment had to be there, even if you won't become an athlete, but you would have to be at least well enough physically, slept enough, fed well enough, and to have showered, to be like all the basic stuff that all of us think about. If that's taken away from you and you're trying to lecture somebody or you're trying to impart someone with cognitive well-being, it's not going to happen. So to make a parallel this with people in their homes right now or in their office or in their car listening to this, having gone through 16 months, however more months we're going to get through this, I think the mental health has taken a big toll in this. And in a bizarre loop, I think, at least from our experience here in Singapore, people have fallen back onto food because food has been the last comfort if you couldn't go out. In some places, you couldn't physically go out. And I'm just wondering, how is that going not to create an additional problem between the fact that people had to cope, and it's human to cope with comfort, and comfort often is associated with food. And that comfort food wasn't broccoli, I'm guessing. It wasn't a salad. And then how is that not going back into the thing that you described, whereby if we're physically coping with something poorly, then how are we going to get to psychologically cope with that well? And whereas the psychology might be the thing that takes us out of it. So could you play that thinking experiment with me a little bit?
Sure. So I do agree with you about the science and the physiology. I mean, what's very apparent is that COVID is an inflammatory disease. So it's not just like catching the flu and you get a runny nose and you feel sick and it goes away. It's not the effect of the infection of the virus per se. It's this mass inflammatory effect that the human body endures, and clearly other conditions don't lend themselves very well to it. It's also fascinating that even the complications you get are not the origins of where you think they come from. They're all immune-based. And so a lot of the drugs, for example, that we use to treat autoimmune conditions or arthritis with actually help a lot of patients to get better. So there is a very strong inflammation link in that respect. But the other thing is that if you look at lifestyle medicine, risk factors, and the science that's there, stress is an example. There's a great paper published in Oxford by a guy called Tawakal, who's also based in Boston, where there's a very strong relationship between inflammation and the risk of heart disease in patients who have increased levels of stress. The same is true about diet and its inflammation risk, and the same is true about sleeping. Sleeping is also related to high cortisol levels and the stress associated with that. I do accept that you need to treat the physiological conditions and the lifestyle conditions first to get the body able to deal with the psychological conditions. And I suppose in my situation, I've been fortunate because it worked that way, even though I didn't work out the mental health aspect till the last aspect of it. I think for the population, it is really, really important to understand that. I think it's really important to realize that you can't do one without the other. And in terms of your point around food, Certainly, if you look at this country as well as if you look at your country, when you're at home, when you're working from home, when you're working in your kitchen, when you are ordering all your food online because you can't go out to the shops, the natural thing is you order takeaways. The natural thing is most of those takeaways are not very healthy. You don't order your salad online here very often. And the one other factor in Ireland which is significant is that the alcohol consumption has increased significantly. It's largely wine derived, which is full of sugar in the vast majority of cases. So, the population's only going to get bigger. And I suppose my comment has always been that the chronic diseases that you see in this world, which also contributed to the COVID survival, those conditions have been around for decades. Those conditions, unfortunately, include both physical and mental health. And those conditions, regrettably, are all influenced by the lifestyle triggers that we've been speaking about. And so when COVID goes away, we unfortunately are going to be left with a massive pandemic issue that relates to people having eating-related diseases, which will trigger the inflammation and everything else. We're going to significant mental health issues, largely because of isolation and also the capacity to function and the stress factors, but also contributed by the fact that most people have responded emotionally, gone back to eating more food, drinking more alcohol, stuck at home and being more inactive. And it's only natural. There's lots of other factors all within that domain that people can understand. So, I agree that it would be great if you had a physiological way, perhaps, to identify things earlier on, or perhaps to monitor people in terms of response. I still think there's a lot of factors that you have to do anyway to achieve that. It's not that you can take certain bits of the diet and suit yourself and see if your inflammatory response yields a bit better to that. I think you have to do as much as you can.
I agree, and I think that often what happens in medicine, but in science in general, is this silo approach to a problem. And for the body, the idea that the body is a linear thing or is an organ-based problem or is a diagnosis issue, rather than saying it's a complex system that is non-linear and adaptive. And the moment you start with these complex system, non-linear, adaptive, you already understand that one fits all is not going to work. And so this concept of personalized medicine then comes into it. And what I wonder is, so what can we do? So because, the constatation of the problem or the consternation around the problem and how dire the state that we're in, I think for a lot of people, the sense is that, right, so if I'm not a scientist, if I'm not a doctor, and I'm in this situation, like you are, Robert, in Ireland, and like I am in Singapore, what can I do? What are the tools that I can rely on? What can I try? Something that I haven't tried before, instead of trying one more pint or one more, chicken curry that I already have tried and this might not be the best thing for me. What might I try that actually might be good and might be the beginning of that chain in that complex system that helps me the right direction versus the wrong one?
So let me share with you my coaching interest of the last 12 months. So I have been trying to help my patients, as I said at the beginning, to change their behavior. One of the things I became aware of in the last 12 months is the idea of what's called an information fallacy. And that is, I give patients information in my office saying your blood pressure is due to this, it's due to this, it's due to that. You take this, you take that, off you go, and you come back to see me. And you may come back and see me within 12 months. And I look at you and say, how are you getting on? You're still eating all the wrong foods. You're still putting a lot of salt into your diet. You're still doing all the things that I told you realistically shouldn't do. So the idea is that if you give people too much information, most people ignore it. The other aspect to this is that a lot of people think that if you're strongly willed or motivated enough that you will change all the behavior habits that you have on your plate. And unfortunately, the reality is you won't. Everybody knows that people who try to stop smoking themselves by and large do not succeed. And one of the great examples of motivation failing is lots of people join the gym on the 1st of January because it's a New Year resolution. And most of them leave the gym by the 31st of January because they haven't been motivated to go there beyond a week. So, the reality is that too much information doesn't help, that trying to motivate people to change behavior doesn't last. And so I was always very interested by this at a personal level because I would find that I was motivated enough to do certain things of strong interest to me. But the reality is I really needed a system or a tool or a method that I could change behavior that was very, very simple. I mean, I've always believed that if you keep it simple for patients, they can actually do these things. So I was introduced to a method out of Stanford in California by a gentleman called B.J. Fogg, who has a book called Tiny Habits. And BJ's premise is the idea that if you would take your behaviors, make them very, very specific, very, very sort of, if you want to lose weight, that as an example, you say that I will eat 5 portions of vegetables every day, Monday, Tuesday, Wednesday, Thursday, and Friday for my breakfast or for my lunch or for my dinner in a specific way as possible, rather than say I will lose weight. And then the idea with this is that you take behaviors that are very easy for you to do. So if you've never eaten vegetables before in your life, it's going to be very challenging for you to pick that as your first behavior. It might be easier just to say, I'll drink water more often during the day, or I'll drink water with breakfast, lunch, and dinner as my specific goals. Now, BJ's method involves you anchoring those behaviors to things that you do every day. So you get out of bed every day. You have breakfast, most people do. You have lunch, you have dinner. So you can say, after I sit down for breakfast, I will eat 2 pieces of vegetable. After I sit down for lunch, I will eat 2 pieces of vegetable. After I sit down for dinner, I will eat 2 pieces of vegetables. There are 6 pieces of vegetables in your day. And the reality is that does work because it's very simple. But the other critical factor is you will only change your behavior if it makes you feel successful or feel good. So one of the key components of using this particular method is that you celebrate to yourself that you've actually done the behavior. And the celebration can be, you can put a smile on your face, or you can do a little dance or do a high five, whatever it is that you feel you particularly like. And if you use that method, you can actually over time change your behavior so that you might start with even 1 vegetable every day if you don't eat it. So to your audience of people, you don't need to be a doctor, you don't need to be a healthcare professional to use a method like this. It's very, very simple. And that example with food is a good one, with vegetables. Drinking water, it's very strongly encouraged to drink about 10 or 12 glasses of water every day. So you might say it's very difficult for you to do that. So how about leaving a glass of water beside your bed? So when you get up in the morning, you drink the glass of water. So after breakfast, I will have a glass of water. After I sit down for lunch, after I sit down for dinner. And remember to give a little celebration, because believe it or not, the little celebration drives your emotion. It makes you feel good. That's the key factor to make you sustain a lot of these behavior changes. So I have been using this on myself. I have been using this with patients to enormous success, because people like making small changes. They are not interested in trying to do big things, even though they think they should. And so, that's the way athletes train. That's the way, if I were to become a marathon runner, I wouldn't be able to run a marathon tomorrow, but I certainly over a period of time would be able to move to a greater distance, build up my endurance, and hopefully be able to do that in the same way that you might want to change your eating habits over a number of months, or you might want to change your habits to improve your sleeping behavior, or you may want to change habits to take up some form of physical activity or to manage stress. So, it's a very practical, simple method. It works. And I mean, it's the best thing I personally have come across as a way to help people change their behavior, rather than beating them up to say, you must do this, you must do that.
That's really interesting, because I remember listening to his lecture and reading his book and thinking the one that really caught my attention was brush your teeth and do some push-up and then go back to finishing brushing your teeth. So every time you brush your teeth, you'll think about doing a push-up. But aside from the technique, which I think is quite interesting, what I also hear, and I wonder how sustainable it is to some extent, is community work, the part of humanity, which means as a doctor, first of all, you need to have time to be able to impart all this knowledge. That needs to be done in addition to the regular doctor work that is expected. And a lot of the doctors that I'm involved with often complain that the way that medicine as a service has been evolving is the human part is shrinking, and the admin part and the delivering of medicine, prescription, is effectively what's there. And a lot of the time, specifically here in Asia, the time that patients have with doctors is extremely limited, especially in hospital, because the volume is very high. And in the psychiatric ward, you could have a consult is as short as 15 minutes. You come in the door and a few questions being asked and any side effects of the medication, and you come out and you realize, everybody in that room realized, apart from the patient perhaps, that nothing exceptional is going to come out of this because you're not addressing the issue, and that issue needs time. So how do we deal with this in the current state of medicine everywhere in the world, where what's needed is this almost collaborative approach of the doctor, A, wanting to do it, B, having the time, the means, and the support to do it, and the patient, therefore, receiving the best of all worlds?
So I think that there's a couple of points to consider. So one of the big challenges is time. And I think the factor around time is people think they don't have it when they actually have loads of it. I think as a doctor, I think as an individual as well, is that people have made life very complicated for themselves when, if you actually were to sit down and try and declutter a lot of your time spent on activities that you don't need at all. I mean, I take a very simple premise in this, and that is, if the activity is going to help you, now that might be personal or financial, well, then you'll do it. But you shouldn't do all the other things that don't help you at all, because that's just wasting your time. And I think a lot of doctors are guilty of that. Now, the systems in healthcare are not very good in every part of the world. And so, we don't even have a universal electronic medical record in our country for our patients, which is really shocking. But so there's an awful lot of extra work created. But so there are sort of situations where ideally if you had more people, but more importantly, if you had better technology and used some of the other innovative connected health measures that you mentioned earlier on, well, that would certainly lend itself. But the challenge is it might increase your time. So you have to be very creative as to how you use that as a potential solution. And I do think as a doctor, you have to decide what you're passionate about. Leave the patient out of the equation for the moment. I mean, are you passionate being a doctor because you like interacting with patients? Are you passionate being a doctor because you like to cut things out of their bodies? Are you passionate about being a doctor because you like the science and that's what you're interested in? Or what are you passionate about? And so you go into medicine because you have to be passionate about some aspect of it, because if you don't, you won't enjoy your job at all. You'll probably burn out and you probably won't last too long in the career. So I'm passionate about engaging with patients. I'm passionate about empowerment around patient behaviour change. And so I've made it my time to do that. So I do clinics in cardiology 2 days a week. I do a session in the cath lab 1 day a week. I spend 2 days working on lifestyle medicine. During the pandemic, which has been interesting, is that social isolation has lent itself to using a lot of online like we are doing here. And so I have been doing group coaching on Zoom. Now, I had to do that, some of it out of hours, because people aren't free. People work during the day, they don't have the time. Healthcare workers like to do these things at lunchtime. I'm not sure you get a full attention of their kind of to the need. And you do have to be creative about blending technology, such as telehealth, such as monitoring to get a better insight as to what people are up to. And you also have to make a decision yourself. Can you get by if you operate as a surgeon, or if you're doing procedures as a physician, by doing them a certain amount of days in the week, doing your clinic a certain amount of days in the week, blending your interest into that? And you may have to see a patient more than once to convey all the information and the change that you do in this respect. You should do it with a team. You should do it with a nutritionist. You should bring on board psychologists if necessary, somebody to help with physical activity. I have tried actually with primary care doctors in Ireland to get the practice to buy into the community that the GP practice is located in. So the local gym may help. The local bank can help with the financial health challenges that we mentioned, or the credit union. The local park can be used for walking. The local restaurant or food market or supermarket can be involved to help with making eating decisions. The community can come together to help older people in a type of security way. And I think this is really, really important. One of the things about COVID-19 is that when you're locked down and you can't get out to see your family or any friends that you might have, believe it or not, the impact of social isolation on your long-term health is greater than any other aspect of your health. And that's the biggest challenge, because when you've been locked down for 18 months, it does become that habit that's very difficult to change. A lot of older people in Ireland are afraid, despite being vaccinated, of going near their children who haven't been vaccinated yet and exposing them to any risk. they're also very afraid to change, to go back to interacting with their own friends, because it was easier to stay amongst themselves at home. They're very reluctant to travel for the same reason. And so, you have a very significant breakup in what would be the true fabric of society, which is we are all out there together, interacting, hugging each other, going to events together. And that, I'm afraid, has a huge impact on health, as you mentioned. So how we connect people is where there's a huge opportunity. How we connect the conversation, how we leverage technology in a productive way, but also I think for the physician in particular, how we connect with other people we work with is a great opportunity for improving patient care delivery. And then ultimately, as I said, your passion and yourself and what you will have learned through the last 18 months, at least I've learned, and I know most friends have learned, is what you truly value in life. We've had a lot of time to think about life as individuals. If it's all about money, well, then that's up to you. I don't think it is all about money, because I think you should value in life that when you're isolated, your close friends are dying, when you have to be very creative to make changes to survive in this pandemic, that you should be able to work out what's important. And it's usually your family and your friends and the people you care about, more importantly than anything else. And I think that when you can work that out, that will impact what you decide you went into medicine or surgery and why you wanted to get involved, whatever else you do in life. And that is what should inform your decision about how busy you are in your workday. And that should inform your decision about how you organize yourself. And that should inform your decision so you actually enjoy going to work every day, so you enjoy what you're going to face into. And that's how you manage healthcare going forward.
That's very interesting. In terms of technology, you mentioned technology a few times. So obviously we've all been exposed to the YouTube videos of Zoom and Zoom, bombs by other animals or other small humans or whatever the case might be. Aside from that, have you experienced a role of technology? And by technology, I mean it's a soup word, but I mean the impact of being on the phone more, watching things that we may not have watched, listening to things that may not be always the best. Have you found a positive or a negative there? Not just technology as a tool to connect in order to be, to say hi, but really as a kill time, because the time that we might have been outside, the time that we might have been traveling, that was taken away from us, and all we could do was revert back to what we had. And in this case, it wasn't a book, or it wasn't something that we would have done 50 years ago. It was a screen. So did you find that there was an impact? And if the impact was there, what kind of impact was it?
So I certainly have found the impact of technology has been in a lot of different directions. So if you take the younger generation, I would have to say that everybody's on their cell phones and everybody's playing video games. There's some wonderful pictures on YouTube and all those other channels showing people sitting down to watch TV at home, and everybody's on a different cell phone doing their own thing. And I think that kids are on the phones all the time, consumed by all the time. I think it would be a wonderful experiment if we could get the whole world to turn off their cell phones for one day. Just to see how the social interaction of being able to talk to everybody might actually work. I mean, I'm guilty of being consumed by social media. I'm guilty of trying to see what other things are going on. I'm also highly entertained to see my colleagues sharing stories around different social media channels. And that's probably a source of entertainment as much as anything else, because of the fact that the whole social connection and interacting in person has been so limited. So I think it's one of those things that's created its own problem. But I do think, as well as you highlight, using Zoom all the time is not conducive to the normal way of living. I think there's been a lot of interesting, humorous experiences with Zoom. I think it's been very useful for doing workshops, doing coaching sessions with patients. And it's also brought a generation of patients into using technology who weren't so familiar with it. Ironically, during the early parts of COVID, for my practice, most of my patients are over 50 and prefer to use the telephone and just talk to me than actually trying to set up on a WhatsApp or whatever other channel they would use. There's a lot of data protection, GDPR rules in this part of the world that restricts the use of conventional, video technology to stuff that has to be very secure and very protected. So there's a lot of logistics involved to trying to set that up, although a lot of companies did try and set that up here. But I will tell you that I have a very strong interest in technology. When I did my MBA, I was interested in disruptive innovation, got very involved in telemedicine. I happen to work with a number of telemedicine companies, one in Europe that does remote patient monitoring, and with a diabetes prevention platform in the States, which actually set up a COVID prevention platform on top of the diabetes platform to allow for people to monitor their signs, like their oxygen saturations at home, to share that information with the network and be advised by a physician as to what they should do or how they should be triaged through the community. So there's been a lot of great innovation in that respect. And one of the interesting things before COVID is that the rules and regulations of using telemedicine, at least in this part of the world, were very restrictive and they weren't paid for. And as a consequence of COVID and the fact that you can't get to see the doctor in person, have completely gone away. And now telemedicine is an accepted form of care, although, as I said, a lot of older people don't want to use it. I suppose one of the challenges I will share is that the use of technology and social media has created a problem for me, and that is the patients come to see me and seem to know more than I do and start telling me that they've been on their Google searches and their other searches and have worked out what's wrong with them. And I'll often say to them, well, why are you actually here? You don't need me. You've already worked it out. And so the sad thing about that is because the world we live in and because of the mental health issues, people have this great habit of catastrophizing because in certain parts of the world, COVID has not been dealt with as efficiently as other parts of the world. A lot of people are sensing doom and a lot of people are worried about what's going to happen next. And therefore, they tend to pick the worst diagnosis they can find on their Google search. So if you have chest pain, everybody seems to pick the lung cancer, as opposed to the fact that they might just have eaten something in their new diet plan, as we spoke about, to cause them indigestion. So it is creating a huge amount of fear in the health world for a lot of people, despite some of the merits that it actually also offers at the same time.
So do you think that at some point, having mentioned some big platform names, whether it's Google, Google, Apple, or any other ones that will come out, or Amazon, do you think there is going to be a time in a not so far future where Dr. Google and Dr. Apple and Dr. Amazon are actually doing the know-it-all, first point of care thing, since we've seen like medication being prescribed online, at least in this region, we have been able to get stuff, done completely digitally. And with the collateral thing, which is all these wearable devices that are becoming more and more medically oriented, blood pressure cuffs, you can do your own. Eventually you will be able to do your own blood test and send the test itself and have the result done. So do you think this is actually a real possibility that the human aspect of medicine is going to slightly or not so slightly disappear and to be replaced by a bulk of AI algorithms and an AI doctor that sounds and maybe looks like you, like a real human, but it's not you? And if so, does it terrify you, or actually are you looking forward to that?
So my comment to that is I'm of an age group where the impact of AI is not likely to be as big as it might be if my children decided to do medicine. I'm very familiar with the topic of connected health and AI. I've taken great interest in it over a long period of time. And I do think it has a huge opportunity, probably as a hybrid rather than as one versus the other. I think with artificial intelligence, the problem is that the artificial intelligence at the moment is based on what somebody's doing, which may not be the right thing. So, for example, my way of practicing cardiology may not be exactly perfect, and an AI version of me may not be the absolute standard of cardiology, and it might differ with somebody else. So that role of an avatar being me may not be exact. The idea of AI screening X-rays to see if it picks up lung cancer or on mammograms or heart disease on mammograms at an early stage is a wonderful opportunity. But it comes with a massive workload in terms of what it'll pick up, how you still have to deal with the individual. The technology won't solve that problem. And I would hope that the art of medicine will preserve and persist, and that medicine won't become so technologically run that it would lose the sense of the relationship between the doctor and the patient. that will be down to the medical profession. And I suppose it's a little bit like the stress situation. Unless the medical profession realize that and come together and engage that, they do run the risk that they will lose the autonomy and the patient-doctor relationship to what the consumer would prefer in terms of ease of access and forgetting about everything else. And unfortunately, I think that will lend itself to a more unhealthy population, because we as individuals will just pick what we want rather than what's best for us. So I think what will happen there is that the business model will shift, because these technologies will be less expensive unless you have to pay a long membership in an idea that you chronically manage your health. But you'll be told how to manage your health by a third party, as opposed to you having any decision in it. It'll probably fall down to how you get paid. At least it does in certain parts of the world, that your salary influences those decisions. So I personally think that if you blend the two, I think having monitoring for patients will be fantastic. The technology is not 100% accurate. I have lots of patients doing blood pressure monitors, but they're doing it where I'm the artificial intelligence telling them how to interpret the results, whether it's happening at certain times of the day, how we schedule the dosing of their medication, how we interact their diet. It would be wonderful if the technology can get to the point of doing that. But also historically, in my age group and above, people don't tend to believe in that enough. They didn't grow up in technology. They grew up on the traditional ways of doing medicine. And I think the other side of this is that the younger generation are the opposite. They're all on their phones, as we described. I think the younger generation are very much the group who will adopt a lot of what the bigger technology companies are doing. You're probably aware, I'm sure you are, that the Apples, the Googles, the Amazons of this world have already invested billions in the healthcare space. Most of them have done it in the US because healthcare in the US is part of your employment. And therefore, there's a huge financial interest from the employer to reduce that cost. And so it's a huge open market financially for the big tech companies. And so it'll be very interesting to see. I mean, one of the things to share with you is I work for a company called Vitos, that's VTULS, who are based in Switzerland. And we have a remote patient monitoring system. It's been very challenging to get that adopted, because different institutions want to preserve their own way of doing healthcare and are very, very resistant to change. And the challenge in medicine in that is that things slip in, just as COVID has actually done. But when it's not COVID, unfortunately, the medical institutions in most of the world don't let other things change, despite a new scanner appearing. But to let technology find its way in there is going to require another disruptive force, a little bit like getting the younger generation much more involved, or alternatively driving it in some space like lifestyle medicine through the younger generation, or bringing it into certain areas where it's shown to be so effective, like the radiology. But I think it is important to work out that the machine doesn't take the place of the human. I think the blend will allow the two to work best together.
Yeah, absolutely. So to conclude this very interesting short journey that we took between Singapore and Ireland today, I would like you to share with the audience what's your weird sauce, both as a physician, as a scientist, and as a human, and whether that weird sauce and how it's come to you, and so that our auditors here can be inspired to think that you can have solutions maybe to problems that they already have and they've tried many things and that hasn't worked, and maybe your component of weird sauce will do it for them.
Sure. So I suppose my weird sauce for me is that I'm not perfect. I'm human like everybody else. And so what I try to do is to have a balanced diet. And in my comment about a balanced diet, I say to patients and every time you eat, that a small amount of food, usually of everything, a little bit of everything is good for you. The emphasis on a little, it's the size of a small plate or a spoon. It's not the size of a big plate. And if you eat everything that there is in food, but you just take a smaller portion, in general, your health will do fine, as long as you're not filling it with Mars bars and crisps and chips and alcohol. That's the key. I try and get out for a walk for at least 30 minutes most days of the week. I have a dog. We walk the dog. I spend as much time with my wife and my children. I try not to work at the weekends, something I didn't do before. I try to stay in touch with my family and to interact with colleagues. I do my very best to get 6 or 7 or 8 hours sleep every night, turning my phone off when I can. But as a doctor, you kind of need the contact. And I'm very conscious of my stress, so I've chosen to do something actively about that, as we've spoken about. So my weird sauce as well would be, don't be so hard on yourself. If you have a bad day yesterday, you had a bad day yesterday, today's a new day, try something else. So if you had a bar of chocolate yesterday, you did that yesterday. Forgive yourself. Don't have a bar of chocolate today. And just, if you keep going in those kind of simple measures in life, you'll be fine. In terms of the technology, be open-minded. There's a lot of opportunity out there. The way you succeed in life is you follow your passion, you follow your heart, and you will succeed, but you have to keep following it. You can't kind of change your mind or give up on it, because then you won't succeed. And the world has so much opportunity as a consequence of what COVID has exposed for everybody. And realistically, between the physiology, the science, the technology, or whether you're a patient-based doctor, whatever it is that you choose that you want to be, everything is possible. And then I suppose for the non-medic and for the individual, who I'm sure are the large proportion of the audience, I do suggest that there are very easy ways to make changes in your behaviour that lend themselves to you being a little bit more healthy. And ultimately, it's not how much you beat your head up against the wall. It's not about how much information you can consume or how many books you read. It's more to do with just making a decision to make small little steps and giving yourself a chance to grow in that way.
Dr. Robert Kelly, thank you so much for having this discussion with us. We wish you all the best in this coming challenges, and big and small habits alike. And we hope to catch up with you at some point.
Thank you very much.
If this conversation stopped you in your track, share it with your network. You never know whose life you might change for the better. Thank you for listening. Stay curious about our next guest, and stay curious about life.